What is your ideal scene? Tell me your ideal scenario. How many offices do you want? How many PTs do you want? How many visits do you guys want to see? What is the lifestyle you want to live, right? Let's build the practice according to the lifestyle you want to live. And according to what Tony wants to live that lifestyle, he doesn't.
Good morning, everyone. Good morning. Good morning. We have Tony Maritato, the host, the co-host with the most. And today we have Amit Gaglani on the show, physical therapist, previous practice owner. Amit, his practice was acquired by a private equity firm, Alliance Physical Therapy, not too long ago, but some years ago. And we'll maybe review that a little bit. He's been on my show before. And also, he's done a whole bunch of things we're going to get into, as well as potentially renegotiating rates and speaking to payers and insurance contracts, maybe getting into some tactical things of like what's even possible now or what you could potentially do as a practice owner to get a bump in your reimbursement rate, your payment rates, as well as some other, CEO type of growth and savvy moves that Amit's been a part of. So Amit, good morning.
Good morning. I feel like I'm on with two celebrities. Like I've watched you guys on YouTube, and now I get to talk to you in person. That's nice.
It's a crazy world we live in. So please, I came into this fresh because I wanted to hear directly from you. Give me a little context about how you got your practice started, how the practice developed, and then, of course, the exit. That's what everybody wants to hear about primarily.
Yeah, sure. So I started my practice in 2004. Quite honestly, had no real aspirations to be a business owner, but just decided to go for it because somebody kept shoving a book in my hand. And I'm sure everybody knows the book, Rich Dad, Poor Dad. So yes, I'm that same story, unfortunately. But fortunately, it did something in my head that made me realize, hey, there's something out there for me more than just what I'm doing every day. Not that just treating patients wasn't enough. And I didn't enjoy it. I actually enjoyed it a lot. And I got my OCS because I really loved orthopedics, loved treating, but I felt like I could do something else and I wanted to do something else. So then I started on that whole idea of, let me open my business, then let me learn about the business as much as possible. Let me be the best business owner I could. Grew it to a certain size and started to feel like, you know what? I really can't negotiate rates with insurance companies. They literally won't even answer my phone calls. They're not responding to emails. It's like I don't even exist here for these people. And quite honestly, once you realize the landscape, like you have a couple practices, you're nothing in their world, because there's more people applying for offices and to get into the network than there are, actual spots available. So it's a circumstance where they don't need you and you need them. So you felt like you're David and Goliath scenario. So I decided that I wanted to partner, whether I was going to partner strategically with a strategic, meaning a larger physical therapy company, or a PE was the question that I had to ask myself. And, I rolled around that idea. And quite honestly, how I did it for your viewers is, I started, taking appointments with them and started seeing how would they value my company. I figured out from the conversations and what metrics they look at from a physical therapy company standpoint and how they would actually put a value, a dollar amount value on my practice. And then I sat back and I said, okay, well, this is how everybody's going to measure it. Let me go to work on building the best physical therapy for the highest value that I possibly can over the next couple of years. And then I'll entertain that offer. Worst case scenario, I've just built a really strong company that has a great, exit opportunity. And even if I decide not to take that exit opportunity, I still built a better company. Yeah. And that's what I really did, and then I decided to go the route of private equity just because the circumstances that they were is I had put in a lot of education into myself to become a CEO of a physical therapy company, and partnering with a strategic, all they wanted to do is have me in there treating patients all day, which is fine. Nothing wrong with that. And for some people, that's great. But for me, I was like, I just spent all this money on educating myself to be a CEO. I want to be able to utilize that somehow, right? And my path for that was partnering with a private equity company that didn't already have physical therapy. So honestly, I just wanted to be a big fish in a small pond.
How did you find this company? How did you identify a private equity that would talk to you, work with you, give you the information you needed to design the framework for the business you wanted to build?
Yeah, so some of it was luck. Some of it was introductions from other people that I knew. There's a bit of luck in everything, to be honest with you.
Absolutely.
In anybody's success story or any story, there's always a bit of luck that could happen. So this one was just that somebody introduced me because they knew that I was kind of doing what I was doing, right? And the more you talk about it, the more people kind of approach you. There were a lot of other private equities that were approaching me that did have experience in the physical therapy field too. So it wasn't just, private equity that didn't have experience. I was entertaining both to see. So really, it was just an introduction that kind of happened, and then I decided I wanted to go down that route, and so then the story really takes off from there.
Let me ask you too, real quick, Dave, before you jump in. How many years was it from you started the private practice to the point that you exited the private practice?
So I started in 2004. And I exited it in about 2017. Mind you, That whole time I had no idea that I was even going to do that. So it wasn't like I started off with that idea. It was just in the last couple of years, 2014, 15, around then I started getting an inkling that I just really don't have the bandwidth to compete against ACOs that were coming into my market. Hospital systems were getting very aggressive in buying over primary care physicians and then telling the primary care physicians, oh, by the way, telling the primary care physicians where they can refer to, although they say, hey, they can go anywhere they want. But the only option they were giving was their own physical therapy, hospital-led physical therapy. And the physicians' RVUs were based on all that stuff. So it was like, you're just mountain climbing at that point. So I just felt like there was a scenario where I was like, you know what, I might be stronger to partner than to kind of fight it on my own.
Yeah. Go ahead, Dave.
I was going to say, maybe we should get a bunch of physical therapy business owners together and buy a hospital. Like, hey, we should go buy NYU or like HSS or something like that. And then we can reverse it.
Yeah. Reversing is what we ended up doing. So, by the way, a little bit of honest here. I was getting, I don't want to say screwed over by the insurance companies for so many years, but really it just felt like you put in authorizations. They're like, oh, we never got the authorization. Just whatever they could do to deny the claims would get done. And here we are, the low person on the totem pole with physical therapy reimbursement being one of the lowest in healthcare, but we're providing such value. And then you're like, why are you beating me up on things that like I faxed it in, I sent it in, like what more can I possibly do? Anything they could do to delay payments or stop payments, you just felt like you're kind of constantly being manipulated by the insurance companies. Maybe that wasn't the truth, and maybe it was just in my head, but it was honestly, it just felt that way. So once Alliance had bought me over, or should say, partnered with me, and then we started growing. We got to a size that we had about 100 practices across the country, and then we're in multiple states, 15 different states from East Coast to literally West Coast. So then I took on the role of National Director of Payer Relations. And that's where I had some fun because I'm like, okay, time for me to give it back. Now we have this many bodies, this many states that we can cover. So I was really, really hard on the insurance companies. Mind you, there was still certain commercial insurance companies that didn't even pick up the phone. They just didn't care because they just didn't care. But with a lot of some other insurances, I really pushed hard against them.
I know a lot of people want to hear about how you were able to negotiate rates. I want to share an experience here locally. So we're north of Cincinnati. We're south of Dayton. We're in a kind of a steel mill town. The steel mill used to be called Armco, then it was AK, now it's Cliffs. And so they employ thousands of employees. They're contracted through, I think it's Anthem right now. And even here locally, like there was one local hospital. They got into a contract dispute with the primary insurance company that has all of the employees locally. And the insurance company was like, we don't care. We are not going to negotiate. We are not going to raise your rates for the hospital. And all of these employees all of a sudden had to start traveling out of the city to get health care. So like you said, I mean, the payer has so much control, and we like to think, oh, well, we're the only provider in a rural area. They need to work with us. They really don't. And so before we got on, Dave was saying, well, Tony, I know you don't like to negotiate with insurance companies. I don't care to negotiate. I've just never seen it done successfully. I would love to hear from your perspective, like, what are some of the things that you notice when you say, okay, this is probably an insurance company that's going to negotiate with us, work with us. This one, no chance. They're not even going to pick up the phone. What was your experience there?
So each insurance company, I had to kind of dig in to take a look at how are they structured. If they were structured as a national company, for example, let's say Aetna, Cigna, those are national companies. Like Blue Cross and Blue Shield, they're segmented by state, right? So they don't care, let's say, per se, that you have 15 different states or 30 states that you cover. They just care what the state that you're asking about. How many do you have in there? So in those circumstances, I just had to look at like, what are our strong states, and then approach it for that specific state. Now, whatever rate I got for that state didn't apply to any other state. So it's really like, what am I looking at as a value proposition for the insurance company? What are they looking at? They're looking at how many bodies that we're covering, how many offices, geographic areas. Are we in certain geographic areas where there's not a lot of providers? So I really just had to get into the fact of, what matters to them. What matters to them, that we have enough practices to cover a lot of their providers, and we might have some practices that are in areas that they just don't have enough providers, or we might offer some specialties or subspecialties that they may be interested in. To be honest with you, and I hate to say it because this is my bread and butter, outpatient orthopedic, regular orthopedic or sports medicine, like we're a dime a dozen, and I hate to say that because I love it, but that's their viewpoint. They're like, oh, are you doing lymphedema? Are you doing some, women's health? Are you doing some things that are more niche than what everybody else is providing? So that's where the jewels, where you find the jewels were like, what can I provide that others may not be providing enough? What geographic regions am I being able to provide it in? For those state specific insurances. For the ones that are national, it's like, we have it in this state, this state, this state. We are growing at this percentage. Look at where we were before. This is where we're going now. For insurance companies. Then for workers' comp, it's like, what matters to them? Certain workers' comp, they score you. They're like, are you sending us progress notes? Are you doing this? And they have a scoring system. So the better you currently are on their scoring system, the better you look. And then, you can apply that. So I basically looked at all of our states with this one workers' comp, and I said, this state has the best score. They're getting the best, not rates, but the best score. Let's utilize that tax ID to utilize for every single state and get that score everywhere. And then we can negotiate a higher rate. So I actually worked with them hand in hand to come up with that strategy. It wasn't me that decided that. They're like, well, if we do it this way, we can apply it to all of them, and then we can give you a higher rate based on X, Y, and Z. And believe it or not, in certain circumstances, I was able to raise our rate by 57%, which is astonishing. But the truth is, nobody had ever tried before.
Yeah.
Nobody had even asked before. Now, before I had joined Alliance and I was on my own, I was able to negotiate with certain insurance companies, workers' comp insurance companies. You have to understand, when an insurance company is coming into the market, they have the most flexibility at that time. So if you're willing to play and talk to them, that's when maybe you can sit there and ask for higher rates and things like that. But here's the sneaky thing that people don't realize. You can get higher rates, but you might not be considered the preferred provider. So what you don't understand is they're picking the preferred providers when they're offering, to send the patients where. For workers' comp, it's not a lot of times the physician dictating where they go. It's basically given back to the nurse case manager. Nurse case manager says, okay, you can go to these clinics. And what they're choosing from is a preferred provider list. So not only was I negotiating higher rates, but I made sure we were on the preferred provider list to ensure that we would get the highest amount of referrals.
What did you see different across states related to workers' comp? Like, I know, for example, here in Ohio, we collect significantly higher reimbursement from workers' comp than we ever could have gotten down in Florida. So it's in our best interest here in Ohio to pick up more workers' comp referrals. Florida, we didn't even accept workers' comp because we just couldn't get anything of a reasonable rate. What was your experience, or what do you remember? What were some of the better states, the worst states in regards to reimbursement?
The higher the population density, generally speaking, the worse reimbursement that we got. We had a practice in Wyoming, and the reimbursement was strong. Like, it was really high. It was very high. But then again, the population density is small, and the patient visits, were small. So it's like, it's where it's harder to have access to physical therapy, where the reimbursement rates were higher, is what we would see. New Jersey, where I'm from, the rates of reimbursement were horrible, unfortunately.
And I'm sure New York. I mean, I hear nightmare stories about New York these days.
Yeah, and Pennsylvania had like a closed system where it just seemed like the one provider was owned by the hospital. and they commanded the highest rates, they also dictated who's allowed in the network and not allowed in the network. But they're the ones who own the physical therapy. So they never would let anybody into the network. So it was like it just didn't make sense. It's like, wait a second, this is a monopoly here. You own the health insurance, you own the physical therapy places. Of course you're not going to let us in.
Yeah. Yeah.
Can I briefly just double click on that $57 bump of I think it was
10%.
10%.
57%.
Oh, 57%. Okay. So in order, like, was that something that you just got lucky? Was it something where you had asked for some over the top ridiculous number and then they, kind of did the whole like reasonable and customary bump or, cut to it. And then it came out to that? Like, how did that happen? Was that luck? Was that some tactics? Like, how would you
So this was an insurance company that we had multiple states in, and then when I took the average of our reimbursement, and then I said, okay, what the new rate that I was asking for, it was a 57%. So just so you know how I got to that 57% number. Some of our states were lower, some of our states were higher, and I was trying to increase both the lower ones and the higher ones. And how I approached it was just like I looked at what they were reimbursing, and I said they can do way better than this. And yeah, I just picked a number that was way higher than what they were giving, but I still thought that it was within reason for workers' comp. It wasn't like I was asking for $300 or $400 a visit. I don't remember the exact number, to be honest with you, but we were starting from a low point too. Nobody had looked at the contract in years and years and years. Nobody had even tried to negotiate it or to ask for it. So, I came from a multifaceted approach. Like, okay, we have coverage in this many different states. We're getting this much in one state, this much in a different state. What is important to the insurance provider and what can I, provide for them? So really analyzing the insurance, finding out what is their, ideal scenario and what they're looking for. They're looking for more coverage. They're looking for places that are growing, because for them, they negotiate with me once and they don't have to do it again. They're not talking to 100 different mom and pop places. So for them, it's easier. And then I became the go-to person. I said, if you see anything in this, and this area, you come to me and I solve it. So it's just trying to, link to the right people. And sometimes, unfortunately, you have to ask to talk to their supervisor and saying, no, I think you guys can do better. I need to talk to somebody that's higher up. Please understand, by this point in my career, I was so fed up with the insurance companies, I had no reason not to do what I was doing.
Right.
And you had nothing to lose because you were already partnered with a bigger firm, right? So it was kind of like you could almost be a little like forward or direct or brash on the phone, right? Like
I was very brazen. And they were like, man, you're really tough. You're really hard on us. I'm like, you have no idea.
Yeah, it's like, you guys have been hard on us for decades.
So I said, I'm kind of giving it back to you. That's all.
Really, I'm sorry, really quick. Was there a playbook or something was it something you developed over time with what to say and how to say it to the insurance companies? Was it because Alliance, you were one of the earlier practices, and this was more on my show when you and I spoke on the interview, but
so
they acquired you early on. Did they give you a playbook of scripts, what to say, how to follow up, all that, or you just kind of created it over time?
Yeah. So when I was one of the first partners that joined Alliance, like I was like literally one of the first partners that joined. So I initially, when getting started, the whole C-suite had no idea about physical therapy. They were involved in healthcare, but not really so much. So I was really involved in helping them with KPIs and things like that. Goes early on, right? Like I said, I was trying to be a big fish in a small pond. So I was really helping from the very beginning. Later on, we got a CEO that had been a part of other physical therapy companies and had more enterprise experience. But what happened was I took this position on during COVID. I wasn't needed in the clinic, right? So what else was I going to do to add value? So I said, okay, let me take on that position and start talking to insurance companies, start getting somewhere. So the position actually happened literally during COVID times when we weren't seeing that many patients in the clinic. So I started a line of communication with all these insurance companies at that time. And literally, I just took it from a point of view of, what would I do? What do I want to see? And how do I get really around to it? So I guess you could say I created it. There wasn't a position there before. They had tried to get somebody to do it before, but I was told that it just wasn't successful at all. So once again, I had nothing to lose, right? The person who tried it before wasn't successful at it at all.
You brought up a couple points that I think are interesting. And context is everything. It always is. So when a therapist sitting at home, small provider, the big one, I'm not going to mention the insurance name, but there are a lot of day rates out there. So insurance companies paying $50 regardless of what you do, $35 in some cases. Therapists sitting there are like, I need to negotiate a higher rate. A couple things that are important, though, is even if that therapist doubled the rate. Okay, so we go from a $35 day rate to a $70 day rate. They're still not going to be profitable. Still not going to make a difference. My issue with all the talks around Medicare is an example. Even if Medicare for me added $15 on average per visit for 4 units, it's not going to move the needle. That's not going to make a difference, but they would never even give me that kind of increase. For you, or an operation that's got so many locations, so many providers, such scale, a small increase in revenue is going to translate into a sizable profit margin at the end of the day. So it's like, on the one hand, we have to look at who is the entity negotiating, what kind of power, control, influence do they have? You guys had more than I do. And then we have to look at how impactful is even an increase going to be? I see several therapists that talk about a payer that pays $50 that got a 10% bump. $5 is not going to make a difference on a day rate like that. So to Dave's point, yeah, I'm not a huge advocate for most of the viewers worrying about negotiating rates because it's not going to move the needle. I want sizable impact. I want something that's going to add hundreds of dollars an hour, not $5 an hour. But I do think it's inspiring for clinicians to know, hey, look, what you did, you looked at the consumer. In this case, the insurance company is your consumer, and you said, what's important to them? Where's the value that I can deliver to the insurance company, and how can I leverage that value to negotiate higher rates? I think it's awesome. I love it. I think it's great. The other thing I wanted to mention, which you said, and you and I have kind of been in the game around the same time. I started my first physical therapy clinic in 2002. 2002, yeah, long time. I would have never heard a surgeon getting pressured to send a referral, keep a referral in-house. Would have been unheard of at that time. I think for me, it was probably around 2014, I started to hear management in hospital organizations saying, we need to keep patients in-house. We need to refer to our own therapy providers. We need to do this. And part of the reason why I heard it, not just from patients, but I would treat office managers for primary care groups that were owned by the hospital. And the office manager would tell me, yeah, I can't believe it. Management came in. We had a productivity meeting. They told us we have to keep outpatient therapy services in-house. So, but then what I started to see, so go through the timeline, early 2000s, mid 2000s, nobody's getting pressured to send therapy referrals anywhere. It would usually be, a brother-in-law or a father-in-law was a doctor and they send all their patients to that therapy provider. Totally get it. Then to mid 2014, 15, start hearing about the pressure. Now what I see though, and I think this is the opportunity, so many physician groups, surgical groups got acquired. They joined hospitals. They hated it because they used to be private practice owners. Yeah. Now they're employees. Now they're starting to refer away from the hospital just to spite the hospital, just because they don't want to send the hospital more customers. And I'm the beneficiary of that. Yeah. I get referrals and I talk to the orthos and they're like, I'm sending you this guy. I'm sick of the hospital. They don't care about the therapist. They like the therapists that work for the hospital, but they want to spite the hospital. They're frustrated with their employers and they want to kind of stick it to them. And so they send me those patients, Have you guys had any experience, Dave? I bet you for sure have some stuff like that going on where docs would rather send to you than to send to the hospital.
I mean, we're definitely seeing it. I thought when you were talking about the timeline there, and I would love to hear what Amit has seen or what he can recall, but the timeline of the referrals of these healthcare systems being kept in-house, I think kind of goes back to the combination of like all the consolidation, all the physician practices, the primary care is being acquired, like you said, Tony. And then like the ACOs and bundled payments, and there's like so many of these like market forces, right? I mean, like that result in this. And then whether it might also have been a combination of with the consolidation of buying up those physician practices and the healthcare systems buying up any of the independents. So whether it was cardiology or nephrology or any of the other specialty physician practices buying those up, some, I'm sure multiple business people that were also buying hospitals, like for example, and not to get political, but like Rick Scott in Florida, he had bought, I think it was Columbia Healthcare, and they had rolled up and bought like numerous different hospitals. And it might have been something as simple as that, like whoever business people, groups or whatever that were buying the hospitals, they were like, hey, like this would be a genius business move. Like, let's just acquire all these other players and keep all the referrals in that system instead of referring out. In terms of business, like it makes sense. In terms of the independent providers, physicians or physical therapists, then we get the shaft. So I don't know if you have, and if you recall any of that, Amit, in terms of like any of those market forces, ACOs, bundled payments, the consolidation of all the practices, maybe all of that and other things.
It's exactly what Tony was saying. And yes, I have friends that were bought out. Now, initially when they're bought out, they're like towing the line. They're like, yes, we're referring, but then something happens and I don't know what it is. Either they just feel like, the funny thing is they're selling their practice and yes, they're doing that, for financial means. So then now they become an employee, but they're not used to being an employee like that. They're not used to being told what to do and things like that. So after a little while, then they start rebelling back. And then they just say like, I'll refer to whoever I want to refer. They can't really stop me from referring, but initially they're like, oh, we have to do it this way. We have to do it this way. So it really depends. Like once they start being treated like they're an employee and told what to do, for a person who's been in private practice for a while, that's a tough pill to swallow after a while. So that's why sometimes, and I hate to say it, but sometimes business owners make the worst employees because, they're used to doing things their own way. And physicians are the same thing. They're used to doing things their own way. They have the referrals. They have their referral patterns that they've been established with for a long time. They like who they're sending to. They know what they're getting. They're sending to a hospital system and they might have 12, 13, 15, PTs, and who knows who's seeing them stuff. So when they get lackluster results, when the patient comes back and says, I'm still complaining about my knee and I don't have full extension on my post-op knee, and it's been like, 5-6 weeks or longer. And the surgeon's like, I didn't really have these problems before. Now I'm having these problems. It makes me look bad as a surgeon because the therapist is not doing what they're doing. And then you find out that sometimes the hospital physical therapy department has a 6-week waiting period, so they get upset about that. So they're going to say, let me just send to who I want to send to, and I'll get a better result. So I totally see it.
The 6-week waiting period, I talk about that a lot. Like when we're looking to find our advantage as small providers,
yes,
that is a huge advantage. And when I would go in marketing to orthopedic groups or primary care groups, I basically told them 3 things. I said, look, your patient might not get better, but I promise you they're not going to get worse because our team will not push your patient beyond the scope of what that patient can handle. I just talked to a patient the other day who quit going to a larger corporate-based clinic because she felt like, these are her words, not mine, the therapists were too young, they were too aggressive, and they made her do too much. And so I'm sure they were doing amazing work. I'm sure they were doing a great job, but they didn't quite get what that patient was there for. That patient wasn't necessarily there to be pushed to her limits and to improve quickly. That patient was there not to get worse. And so our kind of marketing was always, we're not going to flare your patients up. We're not going to send you back angry patients. We're never going to give them a surprise bill that they don't know or they don't expect. And we can get your patients in today. Like literally, I don't care how booked my schedule is. If you call me, I will take a patient right now. And multiple times over the years, I would have primary care physicians, orthopedic offices. They would call my clinic. They would get me on the phone and they would have a patient in their office when they call saying, I need to get this person in right now. Can you see them? And I would get them in right now, and so that's the idea that I don't think there's a single employed therapist working for a hospital-based clinic that is going to drop what they're doing and take a referral in 20 minutes with no prior notice.
Hold on. Have either one of you seen the movie Patch Adams?
No, I know the movie Patch Adams, Robin Williams, but I have not seen it.
So you got homework tonight. You got to watch. I'm giving you homework because you have to see this. So there's a very famous line, and I've used this line countless times on different interviews and stuff. Treat the person, not the problem.
Sure.
So if you treat the person, you will always win. If you treat the problem, you won't necessarily always win. So you just summarize that whole thing. If you treat the person, treat the person, not the disease.
And it's nothing against those therapists. Like I was that therapist. I remember coming from a strength and conditioning background into a physical therapy practice. And I was like, I can't do anything less. I can't reduce the intensity. I can't, there's literally, I would have to learn how to be a Reiki provider and touch the air above your back because I cannot do any lower intensity than what I'm doing. But my patient was still telling me it is too much. So I understand those frustrations. But I also know with time, with experience, you figure out strategies to disarm, that fear, that anxiety, build the trust, build the rapport. And I just think as a new therapist, I didn't have those skills. As a more mature therapist, that's what developed over time. So what are you doing these days?
So it ties into something that you had said earlier about the individual provider, whether it's worth their time to negotiate insurance. But now that I've sold out of that enterprise and I'm on my own now, I have a consulting company and I have some private practices that, I consult for. And I can tell any viewer that's in the New Jersey based area about, some of the insurance things that we've been able to negotiate. So when you form, so what we had, before with alliances, we had a very large group that had the ability to negotiate, right? So taking that same philosophy and moving it to New Jersey, you can have multiple different physical therapy companies that bill under one, what we call super group. So we've been able to negotiate higher rates, but still keep independence. So for anybody that's interested in that, that's in New Jersey based, they can contact me and I can kind of go over specifically, what that entails, but you get basically higher reimbursement rates for doing that. So I'm involved in that. I'm involved in coaching business owners because I took 5 years in an education process while I was a physical therapist to, become a business owner. I didn't know anything about business. I just kind of was asking my friends, what are you doing? Or what are they doing? And then trying to plug that in only to realize they didn't know what they were doing. So I said, let me go get educated. And I used to take classes to become educated on being, the proper CEO and have a proper business plan and executing the plan and putting KPIs in and being able to monetize and monitor the practice from afar. When you have multiple practices, you can't be in all of them. A lot of business owners, and you guys have probably seen this, they have one office and it's hugely successful and they think, okay, great, I could just keep opening them and they're all going to be that great. Well, a lot of times it's successful because they're in the office. They're seeing what's happening. They're monitoring everything. And that one does great because the boss is there. But as soon as they start opening others, they're like, yeah, but that one doesn't do as well. And that one doesn't do as well because they don't have systems in place to monitor things. So that's what I was really spending a lot of time. So now I want to use that to be able to help other private practices and kind of say, you did this for a reason, you became a business owner now. You're not just a physical therapist. Yes, your intention was to take your skills and to take your unique flavor and to add it into physical therapy on your own, but you've decided to become a business owner. So you need to become educated about being a business owner because if you don't own your business, it will own you. And I'm sure you want to be able to go home at night and live a certain lifestyle. And you didn't get into private practice not to live that lifestyle. So let me try to help you to live that lifestyle. So honestly, just paying it forward, just trying to help other private practices.
Nice. David, did you have something?
So the Patch Adams quote that you brought up, it reminded me, I wanted to run something by you because Tony last week and recently he mentioned that basically like at least Tony's practice in Ohio, he described the physical therapy offering as a commodity. I've never heard an owner own it the way that he did. And the comparison was kind of like my style, like, higher ticket, more one-on-one time. We go to patients' homes and apartments and all that versus what he offers. And so Tony kind of said, like, he understands it. Like he's offering this service. The insurance pays like a contracted rate and it kind of is what it is. Now, back when you had your practice, you mentioned on my show, Amit, that you guys were for example, always doing manual therapy. That was kind of like one of the things that you wanted to make sure always happened.
Yeah.
Back when you were owning the practice and treating or running your practices, you wanted manual therapy to be delivered. You wanted a certain experience, but at the same time, back then, would you have categorized your service, your offering as a commodity or no?
I don't even think I would have known what that word was back then to offer it that. But no, I don't know if I would have offered it as a commodity. I just, like you said, I know what I wanted. And the truth is I just wanted replicated what I built my practice on and what the physicians that I knew, because literally the physicians had my cell phone. They would call me, they would text me. I would even see them on weekends and things like that. So there was a personal connection there. And that's how I built my practice. So basically, that's what they knew, and that's what I just wanted to replicate. Because any departure of that, they're going to say, "Well, what is this? This isn't what we're used to." And when you're a private practice owner and you're seeing majority of the patients, and you're trying to step out of that role, it is very hard to step out of that role. When all the referral sources know you, are sending the patients to you, telling the patients, "Go see Amit," and then I'm trying to step out, and I'm constantly getting pulled back in. So if I wasn't getting them to replicate what I was doing, there's no way that I could take the higher function on and open more offices and try to be the educator in my practice as opposed to be the person treating, if that makes sense.
Let me ask you, how receptive, because I know exactly what you're saying. You and I speak the same language. We've shared a lot of the same experiences. I've said before, but just to reiterate, so we started the practice. And when I say I wasn't a physical therapist when we started the practice. I was a strength coach, personal trainer. I recruited a physical therapist because I wanted to get into physical therapy. I realized every person walking in my door needed physical therapy. Yeah. They didn't know it, but I knew that's what they needed. I recruited a therapist. She was a traveler. She was set to go overseas and do a travel assignment in Turkey 3 months after we switched to physical therapy. Now she's my wife. We have 4 beautiful boys. Like, it's been an amazing life that I've been blessed with. But what I found over the years was, you, like me, we were doing everything, and people were sending to Tony. People were sending to Kathy. They weren't sending to Total Therapy Solutions. We were in the clinic at 5 a.m. We were in the clinic at 9 p.m. We were, just everything. And we were like, we can't sustain this. We know we're going to get married. We know we want to have a family. This isn't the life we want to live. We did the business training. We learned how to build systems. We learned how to effectively kind of create a framework. The theory at that time was, okay, what I do is successful. How do I clone myself? How do I package what I do and get employees, and I'm doing air quotes here, employees to do what I do, because I know what I do is effective. Well, what we found out pretty quickly, especially as we moved into like 2010, 2012, therapists don't want to do what I do. Therapists didn't become a therapist to do what Tony does. They don't want to be technicians. They don't want to be robots, and they want to do what they want to do. I don't do manipulations. They want to do manipulations. I don't do dry needling. They want to do dry needling. And so my original business model was, I'm going to package what I do, get people to do it the way I do it, systematize it, and then push it out and scale it. That wasn't going to work for me. Plus my personality. I am never going to tell another therapist what to do, even if I disagree with their strategy, as long as it's not dangerous. So when Dave says a commoditized business, it kind of is, in the sense that, we're selling the platform, we're providing the service. It's a little bit plug and play, but I'm okay with that. It's like McDonald's just prints money. They don't sell the best hamburgers, but they have the best logistics and the best back end, and they understand how to run a profitable business. Yeah. I'm happy with building the logistics and the systems that allow me to be here with you amazing gentlemen talking about business instead of in the clinic right now, and the clinic can operate without me. All of this to say, what was your experience, or what do you remember about you being a good therapist and knowing your strategies were effective, but then trying to get other clinicians to do either things the way you think they should be done, or what you did specifically?
So in the case where we would hire somebody that was a student with us,
Yeah, that's a dream.
that was very easy because they just really did what we were doing, because guess what they were doing all that time. So in those cases, it was easy. We definitely had scenarios where the patient or the therapist, wanted to do what they wanted to do, and those didn't always work out. Not because what they were doing was bad, but because they had a more exercise-based philosophy. Now, I was an OCS, but I also did my CSCS, my strength and conditioning specialty. I really love strengthening exercises. But like Dave pointed out, my one philosophy was that every patient that comes into our clinic should get some sort of manual therapy. Your hands have to get on that patient. Otherwise, the psychology is the patient starts to feel like, well, I just go to a gym and exercise. Otherwise, the therapist doesn't interact with me. They don't really do anything for me except point and do this exercise and do that exercise. So I said, for psychological reasons and to show our value. And by the way, there's a lot that goes into this. At the same time, co-pays were starting to go significantly higher. People weren't used to paying $25, $50 for a copay and told to come 3 times a week or 2 to 3 times a week. Previously, that with $5 copays. So now, because we're asking them to pay more money, I felt like we have to give them more value, and that more value had to translate over to hands-on care. I was in an area where there was a lot of other physical therapy offices. We offered Saturday appointments. Others didn't offer Saturday appointments. So it was always like, what can we do that others aren't doing? So it became a philosophy. And I always put my hands on patients because I was trained in Europe. So I was trained in Scotland where everything was like manual based. We weren't really even taught exercises. And I felt like I was deprived in education when I came here, and all the therapists were like, we do this exercise and that. Like, I don't even know what that is. I never learned that. So there I was trying to learn my CSCS and going after exercises. And then I quickly realized, hey, actually my education was good because it was, grounded in manual care, which I can always learn exercise. It's not so easy to read a textbook and learn manual therapy. So, that's what I asked my therapist to do. For some, it worked out great. One therapist I still recall saying, no, I don't touch patients. I'm like, you don't touch patients? Like, no, I can't hire you. I don't know where you're going to work as a PT that you're not going to touch patients, but yeah. So it's just, I guess I got also better at knowing what I wanted and knowing what I needed and making sure that was cleared up from the beginning. Like, look, I have a way that I do things, and this is the reason why these physicians are sending. So as long as you do manual therapy, what inside of manual therapy you're going to do, I'm not going to really tell you what to do unless the patient is complaining, but you got to put your hands on the patients.
Yeah, that's one of the things I love about the profession in general. It's a blessing and a curse. It makes it really hard to brand the profession because there's so much diversity, but at the same time, it allows any of us to do what we believe is best, And so if you want to build a practice around manual therapy, absolutely, there's people out there that do it. Dave kind of makes fun of me sometimes because I always say there's a pretty significant demographic of patients that will never go to a manual therapist because they don't want to be touched. I shared a graphic on my Facebook of the Canadian Massage Therapy Championship. And it was a graphic of an individual on a table. You can kind of visualize it. It was a man in the middle. There was a woman behind him with her legs wrapped around, straddling him. If you do jujitsu, like in a guard position, hands around him, and then a woman in front of him, head to head, like foreheads touching. And when I for a long time, 15 years of our 23 years, everybody got manual therapy. Everybody was touched. I totally relate to what you're saying. I think COVID kind of changed things for us a little bit. I would say we do 1/10 of the manual therapy that we used to do now. But I talk to geriatric patients dealing with some orthopedic issues when they come into the clinic. If they think that, and I'm not saying you do this, but I'm just saying, if they hear anything about massage, immediately they think, go into a room and get naked and lay on a table with a stranger. I don't want that. Like the perceptions are just so warped around what manual therapy is or could be. So I just say, for us, we kind of did a 180. We went the other way. We do focus more just, let's come in, we'll do shorter plans of care. We'll just do a couple exercises. We'll keep it super simple, super easy. You're never going to sweat. You're never going to, get sore. Like we really target a specific patient demographic, but I'm also the person that says I will kind of invite people that hate physical therapy in, not because I want to convert them, but because I still want to give them a chance to see what we can do, and I'm happy to be like, come in 20 minutes, you're done, and just give them this little micro exposure. I'm not trying to change their mind. I'm just trying to give them what they want. And for some of them, they just want to come in to tell their doctor they went. They want to come in to tell their wife to stop nagging them because they're doing something. Like we just sell a very different experience based on what that consumer wants, which is what you said. Understand what the consumer wants. You do it with the insurance company, you do it with the patients, you do it across the board. And the better you understand what that consumer wants, if you're capable of delivering, I think the more successful you are. Dave,
So
what do you think?
Well, I have a question there. So have you built a practice that's what you do consistently? If you have a patient that wants you to do manual therapy more or feels that they want it more, or you realize that, hey, they have some soft tissue dysfunctions that you need to get your hands into, do you say, no, let me refer you to somewhere else that's going to do that? Or do you become the person that can do that for them?
Like anything. So there's a spectrum. So if I believe the patient would genuinely benefit from a manual therapy technique that I can deliver, I'll do it. I don't care. I don't care to touch somebody, do that. I don't do dry needling. I refer them to NovaCare across the street. I don't do manipulations. I refer them to the chiropractor that rents space from me. I don't do muscle energy. I don't do SI joint corrections. I don't do a lot of the things that I know and I see produce results for patients. Science, that's a different discussion, but does the patient feel better with the intervention? I see it. It works. I don't understand why it works, but it does. I don't want to do it. None of my team right now wants to do it. I am more than happy. I probably refer out as many patients as I accept, just because I don't want to be in the business of delivering things that I don't want to deliver. I don't want to sell that. So it's really simple. I don't do pediatrics, right? Nobody thinks it's weird that an orthopedic clinic for adults doesn't see a 3-year-old. But then people start to think, well, why don't you do these other things? Well, same reason. I don't want to. I don't want to. That's not part of the business that I'm in. And as a result, I mean, we've been in business 23 years. We've been successful enough. I've grown the business and changed the business over the years. But I would honestly say probably at this point, 65 to 70% of the patients in my clinic on any given day are recurring patients that we're seeing. We've seen them for a decade. Every condition, they come back to me. They don't want to go to the hospital. They don't want to go to the NovaCare. They want to come back to us because they enjoy the experience we deliver, even though most therapists are like, I would never work for you. That's a horrible, I don't want to do that. So it's interesting.
And that's totally fine. It's like your practice, your ideal clientele. That's totally fine. And I would say historically, when I first worked my first job in treating patients and outpatient in New Jersey, and then again in Brooklyn, my experience was closer to Amit's, which was my bosses, directors, managers, whatever, and my mentors were kind of saying things like, you have to get your hands on patients because, and then I would hear it. I would hear sometimes patients say like, oh, I could just do this at home or whatever, or maybe it was a condition that like it didn't require a lot of hands-on manual therapy. Like let's say they had like a lumbar fusion, right? And it's kind of like, all right, well, we need to do like, stabilization exercises and drills with like good form and all that. And so there's maybe not a lot of need for manual therapy with certain conditions. And so, but you would still hear it. You would still hear, at least for me in New Jersey and Brooklyn, patients say like, oh, well, like I could just do all this at home. Right. And so that is my and Amit's experience. But then at the same time, Tony, like you're offering your clientele, they know what they're going to get. What you want to deliver to that group of that population. And it's not for everyone. And so I think that, like you said, Tony, that's the beauty of physical therapy is like, it is so varied and so diverse that there's certain clientele and certain consumers like of mine would never want to be in an office like Tony's style. But then at the same time, Tony's clientele would never want to have a physical therapist come to their home for 1 hour. And that's the beauty of what we all offer. And that's why we can, have different offerings.
Yeah. And I think if you distill it down, so like you said, I can do the exercises at home. 100% true. Absolutely. What we do a little different in that respect is we understand they're not coming for the exercise, right? They're coming for the socialization. They're coming to have that feeling of being special, of knowing that this person is listening to me. They're hearing my stories. They're laughing at my jokes. Like that's such a huge element in what we deliver. How do I deliver that? Recruitment. Now, why don't I scale to 50 locations? Because I can't find enough people that deliver that experience. I can't find enough people that can listen and laugh and relate. My PTA is amazing with all of the patient personalities. So that's why when we were growing, we grew to 5 locations across 2 states. We stopped and we're like, look, I don't have the skill set or the interest to grow to a point like you did that's going to get us to, being acquired, joining private equity, going that route. I thought I did, but then I realized that that's not in my skill set. So then we went back down. We sold 1 clinic, we consolidated the other 2. And even yesterday, Dave, you'll appreciate this. We were talking about, me flip-flopping back and forth. I've got a therapist, a PTA who's going to be going on maternity leave. I'm like, do I hire another therapist? Do I just change the business model? What do we want to do? And my primary PTA came to me as like, look, we don't need to hire another therapist. Let's just consolidate the schedule. Let's offload some of the lower reimbursing referrals. Wow. And let's just focus on, the people we have. We can make just as much money, not bring on another clinician, and have a happier life. And that's yeah.
Wow.
And I was like, let's do it. You're right. I mean, this I always have to be reminded and kind of pulled back. Like, why are we doing this? What is the ultimate goal? The goal isn't more money. I don't want a bigger house. I don't want a newer car. I want time at home. I want time with my family. I want time doing I was coaching baseball last night. My kids, I make their lunch every morning, breakfast every morning. Like, that's the priority. When I'm 70, I can go back into the clinic and work full time if I need to.
Is Tony crazy? Because I suggested he should just hire a full-time physical therapist. His physical therapist is going out on maternity leave. So I said, hire a different full-time physical therapist. In 6 months, the first physical therapist out on maternity leave, she may or may not come back. Tony mentioned that. That's not my words. That's his words. Yeah. She may or may not come back. So I said, hire a full-time physical therapist now. Last week we talked about recruiting and hiring, and I was all fired up. And then I said, maybe in 6 months, if she comes back, maybe you expand the practice so that the current full-time physical therapist can stay busy. You bring her back in, and you get her busy again. That's just the way I feel. I know I'm younger. Tony has a lot of things established. He's got real estate. He's got an established family, and maybe it's less about growth and less about the more for him. But we want to hear from you because you're doing consulting for practices. So is Tony crazy, or would you advise him to do what he's kind of saying that he's going to do?
So neither of you are crazy. Okay. Everything has to fall into so when I'm going over things with a business owner, I find out, what is your ideal scene? Tell me your ideal scenario. How many offices do you want? How many PTs do you want? How many visits do you guys want to see? What is the lifestyle you want to live, right? Let's build the practice according to the lifestyle you want to live. And according to what Tony wants to live that lifestyle, he doesn't, I can just tell from the personality, he doesn't want to add more stress. He doesn't want to add more clinicians that he has to supervise, and he has to do more. He'd rather take it easy and see what happens. And that's not the wrong approach. He just needs to make sure that he's covering his bases, right? Which is kind of like, Dave, what you're saying. And I've had circumstances many times, and it's not that, when females get pregnant, they already know that they're not coming back. Maybe some may know that, and some may manipulate the system on purpose, but really they don't know until the baby comes and they see, wow, this is what it's like. I don't think I can actually go back. I think I might just have to stay home after maternity. Now you're stuck in a situation where okay, well, I didn't hire anybody because I thought you were coming back. But just remember, by that time, you probably built systems to kind of accommodate the fact that they're not there. So you may be just okay doing that. Yes, you may be taking a loss on the business side, but on the other hand, what Dave is saying is, if you feel like there is a lot of business there, and you're just not exposing or exploiting that business, and you're turning down a lot, you're like, it's okay. I don't mind saying no. I don't mind fitting in this person. We can't take them. Sorry, we can't handle you for another week or two. And you're saying no to those things. Getting somebody on board that suits your personality, and that's the mix you're looking for when you're looking for a therapist. Somebody who suits your personality and suits the environment that you're in and could flourish in that environment. Getting them in sooner and then just kind of building it out. And now you're a lifestyle person. So even if that person decides to come back and there's not a tremendous amount of volume for everybody, I don't have a problem believing that you guys can probably get up to the volume at the time, and you pull back a little bit more, give some over, you mentor more and more, you're there more and more, and you can do it that way. But ideally look for the person that matches your business's personality, so it kind of matches your ideal scene, as opposed to, let me keep adding therapists because I want to build this, multi-million-dollar, practice.
Yeah,
a lot of work there, sorry, but yeah.
Yeah, no, you're totally right. Like, that's exactly the way I look at it. Is I have found alternative revenue models between social media and other aspects of physical therapy that I don't need to grow the business in the conventional sense. And so that's why I would rather, if I'm going to spend 20, 30, 40 hours a week with somebody, I want it to be somebody I like. I don't need to be best friends with them. I don't need to go out with them on the weekends, but it needs to be somebody I genuinely like. We share the same interests. We share the same culture and values. I prioritize that 100 times over profits. And so, like you said, I will always have a spot open on the team for anybody that I like, that I want to support, that goes off to do something and then might want to come back. But I don't want to just bring somebody onto the team to have a pulse and a license, because that just destroys the culture that we've spent 23 years building. So I know we're coming to the end of the time. This has been amazing. The thing that I love most about meeting people like you is you realize just how consistent our ideas are, the messaging, the communication, the words that we use, the language that we speak, the language of business and creativity and success just kind of flows through all of these podcasts and interviews and discussions. What's the best way for people to connect with you, to follow you, to learn more about you?
So let me make sure I give you guys the right email, because unfortunately I gave Dave the wrong email and I wasn't getting his email. So I almost didn't show up today. So I'm sure you guys have show notes. Actually, I don't know how it works on this. Is it better?
I'll put it in the description of the YouTube video, and we'll put it everywhere.
Yeah. So,
just tell us.
Yeah, it's Amit, AMIT, Gaglani, which is GAGLANI at AGMGMTINC.com. Now you can see why he screwed it up, because actually I screwed it up giving it to him. So yeah, and I'll give you my LinkedIn profile so anybody wants to reach out to me, or Instagram, so you guys have ways of reaching out to me. So, but yes, anybody that's in the Jersey area, even outside of that area, that's what I do. I'm trying to help you build your practice of your dreams in a way that suits your personality, which is very big, because not everybody is hard charging. Some people want to have a lifestyle practice that just gets them to be able to enjoy their time with their family, enjoy their time with their kids, and they're not looking to build like tremendous amounts of volume. But I think everybody needs to realize that once you get into business ownership, you are now a business owner. And whether you like it or not, you kind of have to wear the hat, because eventually you're probably going to need to get some staff. And unless you're kind of giving direction to the staff, then they don't really know what to expect from you. So if you want a smooth life, you kind of have to build that around so you can get the types of people that will be attracted to you, and that you attract those types of people as well. And you have a system, and you have basically a business that doesn't cause you stress.
And so think about this. This is a tradition that Jimmy McKay started. Jimmy started the show, started the podcast. He asks everybody to give a parting shot, just a short little thing that you want people to remember. I'm going to start it off. I'm going to say probably the most important thing out of today's episode is you can find 100 different ways to get to your success, but you have to know what success looks like. For me, success is prioritizing time with family. Anything that lets me prioritize time with family, I am successful. Dave, what's your parting shot?
Parting shot is using some of the tactics from today, renegotiating rates, look what is in your region in regards to specialties, like Amit said. And if there are some specialties, like if you're looking to boost your reimbursement rates, look in the area, see what specialties are not offered in your area, and then you could use that as a leverage point. That's something that Amit said today. Otherwise, I don't think you have a lot of ground to stand on with renegotiating rates, but use some of the tactics. And if you guys do use anything from this episode, from what Amit said, please let us know. Give us some feedback. We would love to have Amit back in the future. But let us know if any of those steps or strategies or tactics work for you. How about you, Amit? What's your parting shot?
I will definitely say the Patch Adams quote again, because I think everybody that listens to us here is a clinician and, is doing it for the right reasons to help people. So focus on the person, not the disease, and you will always win. So that's a great thing there.
All right, guys, another amazing episode in the books. Tune in next week, Tuesday, Thursday at 8:30 a.m. We will see you then. Thanks, guys, for showing up.
Thank you.
Hey, it's Dave Kittle. Are you a healthcare business owner or physical therapy practice owner who is looking to figure out your succession plan or exit strategy? We might be able to help. And in fact, we may be interested in acquiring your practice. If you're interested, you can reach out to me. Shoot me an email at dave@conciergepainrelief.com. That's DAVE@CONCIERGE painrelief.com. Or you can call me at any time, 646-781-8884.